All right, so as discussed, we will be discussing about the peri-implantitis and the treatment planning and the management that you can decide when you examine, when you diagnose a particular patient with implants. Having peri-implant situation could be involving the gingiva alone or could be involving the bone as well. So this is from the perspective of general dentist only. Like if you, some of you may be practicing implants in full on detail and may be already used to this management. But for those who are mostly into general dental practice, how to approach the patients who have been given implants and they come to your practice and you have to observe, follow up and review them and continue to assess them, how you can prevent the severity of the condition, prevent the failing implants with the early intervention and the early examination and early identification. So that's the motive of this class, to basically get in early and identify early, diagnose early, and then eventually also know the management part, what comes under your expertise, where the referral would be required, where the surgical management would be required, and where the non-surgical and the conservative management will help your patient. So based on that, there are the new criterias which have been given. There have been new guidelines which have been given to assess the diagnosis, to assess the treatment plan. And that's what we are going to understand and review. I'll share this article also on the group later after the class for you to revise or maybe have screenshots of those tables that we'll study today. So as we know that the new periodontitis classification has been given, and just a second. So the new periodontal classification has also been given for periodontitis, the staging and the grading. Similarly, for the implant situation, also a periodontal peri-implant disease classification is also given. Although it's not diverse as you would find in your natural dentition for the periodontitis, but still peri-implant mucositis and peri-implantitis, these are the two conditions surrounding the implant. So peri-implant mucositis is a condition which involves the gingiva alone. It's a reversible inflammatory change in the peri-implant soft tissue, that is the gingiva surrounding the implant, without involvement of the bone. As there is no PDL, as we know, there is no periodontal ligament. So we'll be talking, when we are talking about implants, in terms of gingiva, the soft tissue around it, and only the bone around it. And then the implant material and the implant prosthesis shape and the material and the surface texture that affects the adaptation of the soft tissues around it. So there is only soft tissue involvement and inflammation, which is reversible in nature, like your gingivitis, and there is no bone loss involvement. There is no bone involvement yet. Peri-implantitis, whereas, is evidenced by inflammatory changes around osteo-integrated implants in function, affecting the mucosa and also resulting in the loss of supporting bone around the implant. It is indicated by 6 mm probing depth in conjunction with profuse bleeding and suppuration. So it would be the counterpart of your periodontitis in natural tooth, the peri-implantitis, where the bone loss is associated with deep probing depths, which have to be more than 6 mm. So for implants, without active bone loss, without profuse bleeding and suppuration, just alone a deeper probing depth will not mean peri-implantitis. Just alone deeper probing depths could be the way of attachment of the implant. So that's why the baseline records of the initial bone levels have to be maintained and have to be reviewed in the appointments to see whether the bone loss is progressing or not. So deeper probing depths alone will not be sufficient to diagnose peri-implantitis. So they have to be also supported by the evidence of radiographic bone loss around the implant. And that has to be progressive after the first year, because the initial first year, the implant naturally also loses some marginal bone. So just remember, this is one of the very important factors here, that it has to be involving mucosa. There should be the loss of supporting bone, not just the marginal bone. and the probing depths greater than 6 mm, conjunction with profuse bleeding and suppuration. Evidence of also radiographic bone loss around the implant is noted. Now, one of the most critical factors for the long-term success of dental implants is the maintenance of peri-implant tissues. So if you want your implants to stay longer in the mouth, the most important part, just like for your natural dentition also would be, for the natural dentition, you're also preventing it from caries, but also from your plaque for the healthy gingiva and PDL. Similarly, for implant, of course, there is no natural tooth crown structure, enamel or dentine, so caries is out of question. But the gingiva and the bone health is extremely important for the preservation of implants. Therefore, all underlying dental diseases must be treated or stabilized before implant therapy can commence. This maintenance is of great importance when dealing with patients who are susceptible to periodontal disease, because this group of patients will also have an increased susceptibility to peri-implantitis. So all the risk factors that you would put your patient for increasing their chances of periodontitis would also affect their success rate of implants, because they will also be more susceptible for peri-implantitis or peri-implant diseases. So also there is a recent evidence which is showing a potential leachable elements from implant fixture in the body. The titanium particles have been identified in the peri-implant tissues of peri-implantitis patients. Although more clinical studies are needed, this will further ignite the thought of taking extra care when dealing with implant patients. Hence, one of the most critical factors for the long-term success of dental implants is the maintenance of the peri-implant tissues and early identification of the disease. So whatever the approach of dentistry is, it is always, and most contemporary approach is now about early identification, early interventions in the minimal and most conservative way possible. To preserve your natural dentition also, you have to identify the risk factors as soon as possible. You have to intervene with the preventive treatments as soon as possible. Even when implant, you would consider it as the most invasive procedure in dentistry. That means the tooth has been lost and all the practical damage has been done to it. But still, even after giving implants, the approach again starts with a conservative approach in the mind, in the earliest intervention, early identification, and early diagnosis. So no matter whatever stage the patient is at, the approach still remains of early identification, early diagnosis, and early intervention. The intervention still remains conservative in approach. So what are the diagnostic indicators that will indicate that the implant is starting to develop the disease, and how you can arrest it in the early stage, identify it, diagnose it, and then plan your treatment accordingly? So that's the basic flow of studying the patient in the follow-up appointments. When you assess the tissue, what are those indicators, what are the findings that will indicate, and then what are the positive findings that will indicate the disease, how will you classify it, and then what would be the severity of that condition that will help you identify the treatment plan. So our motive today is to learn about the diagnostic indicators, then the diagnosis that comes with it, and for the various severities, the various treatment plannings. So let's start with the diagnostic indicators. Other than the early disease detection, the frequent follow-up and regular assessment enables the clinician to modify the oral hygiene practices of the patient. So basically, again, it all depends on the patient's oral hygiene maintenance. You can maybe call them every 6 months to give, oral prophylaxis, but that would be only short-term stabilization of the condition. The long-term longevity of the treatment is absolutely coming from the patient's own motivations and oral hygiene practices. And that comes again in your hands in terms of educating the patient to practice those. So if the disease is detected, it can be managed at an initial stage. Clinical assessment should include identification of how much plaque is there, whether the gingiva and soft tissue bleeds on probing. Is there any increase in the probing depth since the baseline probing depths? Is there any swelling or suppuration present? Is there any mobility seen with the prosthesis part or the implant part? or is there any radiographic bone loss detected from the baseline records? So probing around implant area is essential to detect early sign of disease. It was shown that probing around the healthy peri-implant tissue does not cause damage to the mucosal seal and can be done routinely. So now there has been some initial hindrances and some resistance about probing around the healthy implant, considering that there is a natural mucosal seal around the implant where the gingiva seals the implant, and when you probe it, it can break down those junctional epithelium which is formed. It can ulcerate it, and it can lead to the penetration of bacteria and saliva into that sulcus. But the recent studies are showing that if you use sufficiently low forces, 25 newtons to say, and you're gentle with your probing, then you do not lead to damage because of the probing to the mucosa. So earlier there was a concept to avoid it, but now the studies have shown that there is no damage to that junctional epithelium, and you can safely administer those probings around the implants to study and the increase in the probing depths, etc. So it is well noted that peri-implant tissues are different from periodontium, where there is a parallel attachment of the junctional epithelium around the implant surface. How you would know the cross-section of the gingiva to the natural tooth, where the JE junctional epithelium is attached to the enamel close to the CEJ, and there are gingival fibers which go through the hemidesmosome. So there is an organic attachment with the tooth from the gingiva. Similarly, there is an attachment of the soft tissues of the gingiva with the implant as well. Only the fibers attach in a different manner. The placement of the fibers is not identical to the natural tooth, yet there is a junctional epithelium, yet there is an epithelial attachment present there. But it lies parallel. There is no organic attachment there as there is in enamel or dentine. So this kind of attachment may result in deeper peri-implant probing depths compared with probing around natural teeth. Because of the organic attachment, the natural sulcus around the natural tooth has some resistance to the probing depth, whereas it lacks in the implant. That's why it's believed that when you probe, you can even in a healthy peri-implant tissue, you can go deeper and you can have maybe over-exaggerated probing depth. But therefore, it has been identified that a light force must be used to avoid tissue trauma when you're probing peri-implant tissues. So yes, you have been kind of given a permission to get beyond the mucosal seal, that you will not damage it, but you have to also understand that your probing depths could be over-exaggerated if you're not making sure of using the light, gentle probing forces, because there is no organic resisting gingival fibers there of JE to resist that probe and to stop that probe. So peri-implant probing depths of implants placed in sites which exclude the aesthetic zone, right, which is in molars or premolars, they should range between 2 mm to 4 mm under healthy conditions. In the aesthetic zone, where the implant is usually placed deep, the probing depths are more profound than usual, so they can be greater. Therefore, the initial baseline values must be recorded and there be any change in a later date. That's why I also emphasized before that the baseline values of the bone levels identified with the landmark where the bone is, with which thread of the implant fixture it is correlating. You should note that down in your records. Also should know what is the probing depth in health during administration of the implant, because that will help you in the future appointments to assess whether it's regressing or not. And also the point that we discussed in before was that 6 mm alone probing depth is not sufficient to diagnose it as peri-implantitis. It has to be associated with the bone loss, supporting bone loss, right? And the radiographic evidence of the bone loss should also be available. any other clinical parameter should be considered whenever the peri-implant probing depth is more than 5 mm. So if you have a 6 mm probing depth, then you should definitely see that the bone loss should be around the fixture, and then it should be accompanied by mucosa involvement. There should be bleeding on probing and suppuration present. So that's why all the baseline records and even follow-up findings that you find on your follow-up appointments should be noted on the records as the patient comes and visits you. Even if they are healthy and normal, put them on the records on every follow-up appointment. A baseline radiograph must be established to record the bone levels at the time of prosthesis placement. It is preferably obtained with a standardized film holder, and radiograph should clearly show the implant reference point with distinct visualization of the implant thread. So when you take the radiograph, it should be with the paralleling technique, which is the most reproducible technique, and with a film holder, not arbitrary placed in the mouth with the use of your hand or the patient's hand, but use a film holder. Then obtain the x-ray, and then mark and identify the landmark on the implant, the fixture, the thread actually, which correlates with the bone level. So that when you obtain the future radiographs, you can actually match and correlate the existing bone levels and whether there is a progression of bone loss or not. So you should obtain annually for the first 3 years of the implant function. Every year, at least one radiograph should be taken, despite the presence of symptoms or not. So for the first 3 years, if you want to know that how much exposure would be advised or recommended, it's one every year when there is no symptom also. With disease present, you may be required to take more, but without presence of disease, without presence of symptoms as well, you will require for the first 3 years of giving implant, one radiograph using the long cone paralleling technique method with the holder annually, once every year for the 3 years. Now, most implant systems show a small amount of marginal bone loss within the first year of function, which is normal. So the implant disease risk assessment was introduced as a guide to identify the risk of developing implant disease. Now, this has been developed in the year 2020. It's a risk assessment guideline, right? What puts your patient at risk of developing peri-implantitis? So we have been studying about periodontitis risk factors. The diabetes has been studied long enough. The HbA1c factors have been studied. The how much cigarettes in a day, if you have studied all the gradings of periodontitis, right? So it puts diabetes and smoking right there as the risk factors, right? And the values and the numbers. So all those specific parameters have been now quantified. Similarly, for the implant disease risk assessment, also now the quantifiable factors have been given, which you can actually observe in your patients, identify in your patients, and then assess their risk, and then educate the patient accordingly to prevent that disease. That's the ultimate motive, to prevent the disease, to give the best healthcare to your patients. So for the risk assessment, these 8 factors are history of periodontitis, presence of bleeding on probing, the number of teeth or implant which have the probing depth 5 mm or more, even the teeth, because if the other existing teeth have probing depth 5 mm or more, would indicate the active periodontal disease in the natural tooth, again, which would indicate the risk also for the implant to develop a peri-implantitis, if you know what I mean. Number of teeth, also implant, both with higher probing depths, put the patient. So even if just natural teeth is involved with deeper probing depths and an implant is not yet, but that should put the patient at risk, that because their hygiene may not be correct, the plaque is there, the pathogens could be there, which puts them at risk of sooner or later implant also being susceptible to the peri-implant disease. Then bone loss, how much the bone loss has occurred, divided by the age of a patient. Why this is the fraction is that more the bone loss and more the age, then the value comes out low. But if the age, which is the bottom denominator, if that's low, then the fraction comes out to be higher. That means at a lower age, higher bone loss indicates the poor prognosis for the implant. And increased bone loss at a higher age still is an age-related factor, would still be a better condition than the younger patient showing higher amount of bone loss. Then their susceptibility for periodontitis, compliance with the supportive care, how much compliant they are with the treatment that you deliver them, then maintaining the treatment by following the home care instructions, oral hygiene practices, they all combine together to give you the compliance from the patient and to determine the successful outcomes of your treatment. Distance of restorative margin to the bone crest, because restorative margins also have a tendency to trap bacteria and all. So how much farther it is to the bone crest. Then prosthesis related factors, what is the distribution of forces, the designing of the complete, especially if it's a multiple unit bridge. Then prosthesis related factor also come into the account, depending upon the loads that the implant takes and whether it would lead to bone loss or not. So amongst the parameters which are listed, periodontitis susceptibility includes established periodontal disease risk factors like smoking and diabetes mellitus. Then another significant relationship between smoking and osseointegration implant failure has been noted. So smoking also leads to osseointegration failure sometimes. For risk of implant failure amongst patients with diabetes, no significant difference in the implant failure was found between healthy and diabetic subjects. So smoking has been directly linked with implant failure, whereas for diabetes, there has been no direct link found between implants in diabetic patients and healthy patients. But another study did reveal that healthy patients showed less marginal loss than patients with diabetes. So definitely with diabetes, one thing comes, which is the compromised healing abilities. That's why you could in the first year see more marginal loss in diabetic patient. Other than that, beyond the first year, beyond the loss of marginal bone, there was no difference between the healthy patients and the diabetic patients for the implant failure. There were similar rates. Whereas for periodontitis, HbA1c equal to or more than 7 links the patient with higher risk and the more severity of periodontal diseases. So for periodontitis, both smoking and diabetes are the risk factors. But for implant failure, you can put smoking only as a risk factor, but leave the diabetes out there. Any clinical changes around dental implants must be monitored and acted upon promptly. Now, the progressive bone loss, that there is an evidence of ongoing bone loss. That means apart from the first year, the marginal bone loss that you observe, in the second year as well, if there is a progression and there is more bone loss, that would be identified as a progressive bone loss. The causes can be prosthesis factors, which is occlusal overload. That means the implant and the prosthesis design is not enough and meticulous enough to take up that load, and it's all taken up by the bone, leading to the bone loss. Other is the pathological bone loss, which is coming from the bacterial induced inflammation coming from the plaque. So either it's the mechanical failure through the mechanical factors or through the biological pathological factors. So bacteria induced inflammation is initially treated non-surgically, but depends on the initial clinical presentation. This non-surgical therapy involves the removal of dental plaque with or without the use of locally delivered or systemic adjuncts, right? So that means your locally delivered or systemic antibiotics, right? So lesions with probing depth of 5 mm or more and bone loss of greater than 2 mm will need surgical intervention. So anywhere your probing depths go more than 5 mm and the bone loss is more than 2 mm, apart from your marginal bone loss, that indicates your surgical intervention. So that is one criteria that you need to memorize when you're assessing the reports, feeding it in your charts. Probing depths more than 6 mm, 5 mm, sorry, and your bone loss more than 2 mm is the surgical intervention time. Non-surgical therapy does not provide additional therapeutic value in cases where the osseous defect is involved due to implant fixtures thread appearance and the implant surface treatment. Right? So when the fault and the bone loss is coming from the factors of the implant's own anatomical preparation, its thread shape, its design, and its surface treatments, the non-surgical treatment, that means the scaling and not root planing, scaling and prophylaxis will be of no benefit because those anatomical factors of the implants will persist and that bone loss will continue to happen. So all the disease that's coming through the implant's own anatomical factors, the surface factors, cannot be treated by your non-surgical intervention. Now, for the surgical management, in general, the resective or regenerative surgical therapy, or sometimes the combination, yields promising outcomes. So, as for your periodontitis also, when you do the surgical therapies, they're either resective, that means preserve what's there and remove the compromised bone, right? Or gingiva as well. But do not add through the bone, do not give the grafts, do not give your regenerative therapies where you put the barriers and allow the PDL to regenerate, right? So for the membranes and all. So similarly for your peri-implantitis also, resective surgeries would mean remove what's diseased and preserve what's healthy, right? And preserve the implant at the as-is position, but arrest the progression of the disease, like you would do for your periodontitis situations as well. The regenerative surgeries have the factor that they are costly because you're doing the surgery as well as you're giving the bone grafts and doing the membranes and the collagen membranes and regenerative procedures as well. So there are both. Again, it depends upon case to case. Also depends upon the patient's paying capacity, because of course the regenerative surgeries are the costlier ones, right? But when done in combination, they definitely yield better results than the resective surgery done alone or the non-surgical surgeries or non-surgical procedures. So when pocketing has been noted, using your cumulative interceptive supportive therapy protocol, right? So it has given you again a protocol when you have pockets. So we know that more than 5 mm of probing depth, right? And your more than 2 mm of bone loss will require surgical therapy. So let's see, based on all the probing depths and based on all the bone loss factors, what is the protocol for the treatment? It's a very simple flowchart which has been given for you for your clinical assessment. The moment you find these probing depths and your bleeding on probing factors and your bone losses on radiographs, the moment you have those values, it gets easier to determine the treatment option. So when your probing depth is less than 3 mm and there is no bleeding on probing, that means it's a healthy implant situation and no treatment would be required. When your probing depth is below 3 mm, but the bleeding on probing is present and plaque is also present, it would put the category or it would diagnose the condition as peri-implant mucositis, which is equivalent of your gingivitis situation. So in that stage, you will do mechanical debridement and polishing, right? And may give an antiseptic cleansing as well. But again, a non-surgical approach. When the probing depth is in the gray zone, which is 4 to 5 mm, not enough to categorize as peri-implantitis, and also a progression of peri-implant mucositis, again, that will be including of your antiseptic cleansing. If there is no bone loss, again, mechanical debridement. When the probing depths go more than 5 mm, that's when you know the surgical interception has to be covered. So bleeding on probing is positive, but no bone loss is seen. Again, for peri-implantitis, has to have 5 mm and more probing depths, plus 2 mm and more bone loss. So if there is no bone loss, still surgery is to be avoided. It will remain, again, non-surgical management. So both the factors have to be positive. When you are charting, please see bone loss 2 mm and more, probing depths 5 mm and more, both positive, then you start surgical thinking. Anything below that, anything in lack of that would be your non-surgical management. So no bone loss or bone loss less than 2 mm, non-surgical. No bone loss, probing depth maybe 5 or more, still doesn't qualify for surgical unless both the boxes check. Probing depth and bone loss. Both the boxes have to be get checked to come to the surgical intervention. So 5 mm and more than 2 mm, again, less than 2 mm, still your mechanical debridement plus your systemic local antibiotic therapy. So what will happen if the probing depths are more than 5 mm, but bone loss is not checking, so you'll still remain non-surgical, but because the probing depths are deeper now, you will incorporate to the mechanical ones the antibiotic therapy, which could be systemic antibiotics or the locally invested within the sulcus antibiotics, right? Now, the final and the most severe situation would be where the bone loss is also more than 2 mm and the probing depths are also of more than 5 mm. That's where you would do resective or regenerative surgery. So the aim of surgical therapy in peri-implantitis cases is to increase the cleaning ability of implant surface, because in deeper pockets, the plaque will continue to retain and pathological activity will continue and the pathogen will continue to lead to the bone loss. That's why when you do the surgery, reduce the probing depths, it becomes a self-cleansing site and it becomes easier to clean as well, and correct the condition of soft and hard peri-implant tissues. So it will improve the conditions of the existing tissues. Re-osseointegration is the outcome to be gained following the surgical procedure. Resective or regenerative surgeries are proposed to treat peri-implantitis depending upon the anatomy of the bone defect. If the site has supra-bony defect or a one-wall defect, resection with osseous surgery and apical repositioning flaps should be performed, right? So when your most of the bone loss is still limited and involving only one wall, then you do the resection surgery and you can raise the flap, position it at the existing bone level without having to put the bone grafts and doing the regenerative therapy. The main aim of resective surgery is to eliminate the inflammatory tissues. So all that granulated and ulcerated gingiva as well as the bone will be debrided and it is placed at the newer bone level, providing you the reduced probing depths also, reduced sulcus also, which will prevent the plaque accumulation there. And it will also hence improve the hygiene measures and hygiene efficiency. Plus, it will stop the disease from progressing further because there is no more plaque accumulation into those deeper pockets. To maintain the implant in function with healthy peri-implant tissues, so you can prevent the mobility also, you can maintain the implant function. It will reduce the pocket depths. It will gain a soft tissue morphology, which will allow the cleansability for the patient and leads to, again, peri-implant tissues, which are healthier. For the circumferential bony defects with intact bony walls, so bony defects which are involving throughout the walls, all the 360-degree, all the 4 walls, a regenerative surgery with natural bone and collagen membrane showed promising results compared with other types of bone defects. So a peri-implantitis situation, which was treated with regenerative surgery, is shown here, where there was the 3-dimensional bone loss around the implant. As you see, all the 4 bones around it, the mesial, the distal, and the buccal and the lingual, all the 4 walls have been lost. But you also see that the defect is somewhat of a vertical loss. Do you see the gap between the implant and the bone? Do you see also that it's not just supra-bony defect, it's kind of an infra-bony defect. So at some place, the height is maintained of the bone, but there is a vertical defect within the bone. So the base of the bone is still intact, but there is a infra-bony circumferential bone loss. Can you all appreciate that? around this implant? I want you to take a moment and see that it's not an unified bone loss, because supra-bony defects are difficult to repair through the bone grafts. A bone graft can build up the thickness of the bone, but it's difficult to achieve the height of the bone through the bone grafts. Does that make sense? To achieve the full thickness and the height in a supra-bony defect is difficult through the regenerative therapy, whereas regenerative therapies, just like your natural teeth, are more likely to be successful in the infra-bony defects. Can I have some yeses or nos to understand that you're getting the idea? And you can see the infra-bony defects here. Like the height is still there, but the thickness of the bone is lost. So it has left the implant. The bone loss is happening vertically here, right? And that's where the regenerative surgeries are most successful, because you have a scaffold, you have a base on which the graft will take hold and then will osteointegrate with the implant, right? So those are your naturally successful case selections. This was done, and you would see that again, you cannot see the fixture anymore, and you were able to put the graft and the height was restored along with the thickness. A systematic review was concluded that regenerative surgery combined with membrane placement has better outcomes than other methods. Given the unsteady outcome of peri-implantitis treatment, preventing the disease is better than treating it. Because if the supra-bony loss happens and only one wall remains, there is no chance that implant can survive for longer periods. Yes, you can maintain it in function for shorter durations, but the prognosis gets reduced as much as the bone loss increases, as much as the walls involved increases, right? The best prognosis would come from the circumferential vertical bone loss around the implant, which can still be regenerated through the graft and the membrane method. Now, given the unsteady outcome, it is most important to preserve the implant, prevent the disease, rather than trying to treat it. During the review, a complete intraoral examination should be conducted to detect the early signs of disease. Good oral hygiene must be performed to maintain healthy peri-implant tissues. The use of toothbrushes, either manual or electric, helps reducing the amount of black biofilm. Flossing is extremely important in implant situations, which will include suprafloss or superfloss and interdental brushes, depending upon the location and the gaps. And oral hygiene for the patient must not be made too complicated or prolonging the time required by using. So that you don't add too many aids for them, otherwise it will get complicated and they can lose the motivation to perform it every day. A crossover flossing technique can be used, especially when single implant situation is seen and they are in the aesthetic zone, using your regular floss. A poor flossing technique or no flossing at all can lead to subgingival inflammation of the peri-implant tissue. So flossing is of extreme importance in the implant maintenance. A correct subgingival flossing technique can result in the formation of epithelialized sulcular tissue down to the implant neck, which will maintain the mucosal seal again. If the implant placement is not in the ideal position, this can lead to difficulty in cleaning, and the prosthesis may have a ridge lap profile as well. That also makes it difficult to floss. So in those cases, you have to modify the hygiene. You can suggest them to use tufted brushes, interdental brushes, or super floss, right? Which is stiffer and penetrates and helps in cleaning. In premolar and molar areas, the use of floss is recommended in the case of a single unit implant. In your fixed bridge prosthesis, where you also have to go under the prosthesis, a super floss or an interdental brush is indicated. Super floss is a stiffer floss which can penetrate the difficult areas without bending and without involvement of dexterity. Now, calculus also forms around implant, very similar to what you'll find on the natural teeth as well. But the difference is the method of attachment to the natural tooth versus the method of attachment to the prosthesis and the implant. So because they're highly polished surface, the calculus doesn't get impregnated deeper into like it would get into your enamel and dentine. And that's why the removal is far easier. So preferably you should use your plastics and and your carbon fiber instruments to prevent any damage to the prosthesis and the implant surface. Ultrasonic scaler is never used on an implant. The metal tip especially is never used on the implant. Only the plastic scalers are used, as the ultrasonic ones can lead to heat generation and can damage the bone, which helps integrate the implant. That's why when you're doing your mechanical debridement also should be done with hand instruments, curettes, and specially made of plastics preferred. Now this is an example of an 8 mm deep peri-implant situation. It was treated non-surgically with local delivery antimicrobial. So you get it more than 5 mm, but no bone loss, will be treated with mechanical debridement, but an adjunct with systemic and local antibiotic involvement. Does that make sense? Do you remember from the protocol, the CIST protocol that we just did? More than 5 mm, but no bone loss. And what did you use? The non-surgical treatment, but with the adjunct of systemic or local antimicrobial delivery. That's where you see the application of that protocol here. Very simple to identify if you remember that chart. So any situation you're given, any findings you're given, whether in your clinics, whether in your exams, whatever the values of the pockets and the bone loss, you just have to mentally calculate where the patient would lie at, and then simply apply the protocol and you land the correct management, right? And you use the non-surgical management, but because the pocket was more than 5 mm, you administered the antimicrobials. Here you use the local delivery ones, and the patient was also using chlorhexidine gel with the large interdental brush. After 2-week review, the pocketing associated with upper right lateral implant had reduced to 5 mm with simple non-surgical therapy. Whether any further intervention is needed or not, then you will recommend to specialist and continue to observe as well whether it's progressing or improving. So management of peri-implantitis is not straightforward, and the outcome varies depending on various factors. Current evidence showed that the surgical therapy should be carried out in treating peri-implantitis. Moreover, the regeneration is highly recommended wherever possible. However, more homogeneous studies are required to support the current evidence. Now, coming to the question, I think that Jinal you asked is how would you identify from the picture? If you go back above, and if you, I don't know if you've attended any of my periodontitis lectures of the natural teeth, we've studied, okay, let me show you if I can quickly draw it for you to give you a visual. So I'll show you with a natural root. So in a healthy tooth, this is your bone levels, right? Similarly for your implant as well, if you're giving implant, suppose this is the implant. So once you give the implant, you, as I discussed here, you have to get a baseline levels of where the bone was when the osseointegration happened, right? So that's on radiograph. Suppose it was on thread number 1 here. This you will keep a record on the patient's chart as well. And this is your natural tooth, right? And then you have the biologic width. Then you have J, then you have gingival connective tissue fibers. That's how you have the natural tooth anatomy as well? Here you would also have the natural gingiva, but the J would be arranged mostly parallelly to the tooth rather than the perpendicular here. So can you see here? Can you appreciate the normal, at least gingival and the bone anatomy around the implant and the natural tooth? Everyone here, can you see my screen? So supra-bony loss is when you lose the bone from both the dimensions, height as well as thickness, and that's how you continue to lose the disease or lose the bone, right? In your periodontitis, in your generalized periodontitis, the bone loss happens supra-bony, right? That's how your bone levels reduces. The probing depths, the sulcus keep receding apically, and your probing depths continue to increase. That's what happens. With the ulceration of JE, the breakdown of the gingival fibers, and then it attacks the bone. And that's how the bone recedes, supra-bony loss. And the sulcus goes down and you have deeper probing depths, right? And when you move the probe along the sulcus laterally, there is no bone within this gingiva. So your complete sulcus would flex. This gingiva would be, you will be easily able to flex it because there is no bone, right? Bone is apical to it. So when you move the probe buccally, maybe, will your marginal gingiva flex? Is that correct? So that's your supra-bony bone loss, right? In your periodontitis. Now, similarly, let's talk about your vertical bone loss. So vertical bone loss happens not in your generalized periodontitis. That happens in your food impaction cases. That happens in your aggressive periodontitis, right? So in those situations, you lose the bone only on the vertical aspect, on the internal aspect of the bone. The height of the bone still remains, but the thickness of the bone is lost. So all this blue area that I'm marking here is the vertical bone loss, and the height is still remaining there. So your gingiva also recedes because the bone loss is happening. So your probing depths are definitely increasing when you probe. This is your probe, right? So your probing depths are increasing. JE is going down. The probing depths are increasing, but there is some thickness of bone which is within the marginal gingiva. So do you think when you try to flex this one, your wall would move? No, right? Because it still has the bone. So this is your infra-bony defect or the vertical bone defect. This is your supra-bony defect. This is your infra-bony defect. This is the basic anatomy of the loss. Same goes to your implant situation. Either your implant can lose the bone both in height and width. And that's when you raise the flap surgically, you position it back on the existing bone levels because you don't want increased probing depths here. So you reposition it here, right? Of course, it's exposing the implant. Of course, it's not an ideal situation. That's why it's a complicated process to preserve the implant once the bone loss occurs. That's why prevent the bone loss. But with the supra-bony, the graft will not increase the height and width both of the implant. You could try it, but you would be only able to achieve little bit of height. 100% success does not come out. You will not gain the entire height and width. That's why the resective surgery alone is done. You cut down the excessive probing depths. And that's called your gingivectomy, and reposition it on the existing bone levels. It will expose the implant for sure, fixture, as it would also expose the roots if you did it for a natural root. The best is your regenerative therapy, which is also the best prognostic condition for an implant, is when it has lost the bone vertically. So how on picture you would see it, because you have a baseline of where the initial bone was when you place the implant at that point. So you'll have a baseline picture and radiograph, and then you will take a picture on that day where the bone loss is seen and the radiograph also. So clinically, there would be a certain amount of implant that would be seen with the bone completely intact around it. But when the bone loss has occurred, if it has occurred supra-bony, you will see the fixture and the bone level would be below, right? But when you have vertical bone loss, you will see that the bone height still remains to the level where it was or has slightly reduced, but it has created a gap around the implant because it has vertically resorbed. So if it was vertically thicker and closer to the implant initially, because it is losing it vertically, so it has created a circumferential gap around the implant, because it's reducing in the thickness. So it's going outside. So height would certainly remain slightly higher. It would not be a supra-bony defect, but an infra-bony defect, and it will create a gap around the implant. And that's what I was trying to show you in that clinical picture as well. This well-like appearance. If I re-show you that, can you appreciate the height here? But a circumferential infrabony. So here you see suprabony loss also. Both height and width are lost. But here you see the height and the width getting lost. Jinal, can you appreciate it now? Yeah, so your eyes will only see what your mind knows. That's why it's really important to know the concepts, and then you will be able to identify them in the clinic with your eyes also. So trust me, what you don't understand as a concept, you will never be able to see, even if it's lying in front of you in your patient's mouth. But once you know these concepts, you will immediately pick on them. You will immediately learn and identify them and start taking correct and timely action for your patient's well-being. And that's the intention of these entire classes, the monthly classes, is to continue delve into more clinical situations every month, see what we should know more in depth clinically and theoretically and conceptually, just so that we are able to identify it easily and quickly and timely in our patient's mouth in our clinics. So that would be it for today's class, and thanks for being the great audience that you are. And I'll hopefully see you next month. I'll put the topic and I'll search for it, put it there on the group, what we are discussing next month, the dates also. Probably by the first or second week of January, I'll put the information out there, and continue to study well and keep learning. Thank you so much for taking out the time for learning, and I appreciate it. And thank you so much. And see you next month. Bye-bye.